know what that gradation means. Anything else we can do? What do we do for Lauren? Okay, we changed the pad. We did do a fundal massage. Would a fundal massage work for Sarah? Why? Her fundus is already firm. What else did we do for Lauren?
Ask her how long it was on.
We asked her how long it was on and we changed it. Did we also take vital signs? So ask her how long she's had it on, change it, check her vital signs. Maybe she's just had it on for a super long time. We'll see. So Sarah states that she changed her pad when she was up in the restroom about 45 minutes ago. So you change it again and you check her vital signs. Her blood pressure is 98/66 and her pulse is 110. She also states that when she got up to use the restroom, she felt weak and dizzy and her husband had to help her back from the bathroom. What do you think is going on? She's hemorrhaging. She's losing volume. Something is happening somewhere. She's bleeding, but it's not from her placental site. How do we know that? Because she has a firm fundus. Does that make sense? So I said that a boggy fundus is the most common cause of bleeding in the first 24 hours. I never said it was the only cause. For clients that have had operative vaginal deliveries, we really need to make sure that we didn't inadvertently, or not us, but the provider didn't inadvertently miss a small cervical or vaginal lap. So her fundus is firm, but she's definitely losing volume. So what should we do? Call the provider? What do you guys think? Call the provider. And yes, we would definitely want to replace that volume. Any questions so far? Okay, the provider came and assessed Sarah and determined that the forceps inadvertently caused a small cervical laceration. Since Sarah had an operative vaginal delivery, what other problems would we want to look for in Sarah? I'll give you guys a minute to talk about it because y'all are too quiet, and then we'll get back together.
Infection? No. That's all I can think of. You don't have to bring it. Yeah.
What do you guys think here? What are some other things we should be looking out for in Sarah besides a saturated pad? Okay. Like what sort of trauma? Okay, maybe. Anything else?
Infection.
Pain, infection, okay. Emotional status. Anything else? She's definitely losing volume. What if her pad had been clean? Internal bleeding. We did stick some big stainless steel salad spoons up there, right? A hematoma. A pelvic or perineal hematoma. What are some signs of this? Pain. Significant bruising. Changes in vital signs. How much volume can a client lose into a pelvic hematoma?
500.
I think it's spelled out in your HEI book. They can lose up to how much volume into their pelvis once the baby is gone? Close, about 500 mLs. And we will see nothing on their pad. So some signs and symptoms: severe pain in the perineal area, swelling and discoloration of the perineal area, and change in vital signs. That's not up there, but it should be. I've only seen this once in my entire life. We had a client who went natural, absolutely nothing for pain, for an 8-hour labor. No epidural, no nothing. She pushed out an 8.5-pound kid, nothing. And then I took care of her in the postpartum period, and she calls me to her room and she's just weeping. And I'm like, what's going on? She's like, I'm in so much pain. I said, where is the pain? And she said, it hurts really bad between my legs. This hurt worse than labor did. And I'm like, that don't sound right. Labor is pretty painful. But I rolled her over, and I'll show you guys a picture. This isn't her picture, the patient that I had, but it's very, very similar. So Sarah was taken back to the labor and delivery unit to repair the laceration, and we returned to Lauren. So perineal hematoma, what are some risk factors or signs and symptoms? We talked about some signs and symptoms already. How about risk factors? Operative vaginal delivery. Large baby. Usually not a C-section. Women can lose up to 500 mLs. Lochia flow remains normal, but she can have a change in vital signs. Her fundus will be firm. She can have significant bruising. So this is what, similar to what my client looked like.
Oh my gosh.
So the doctor had to go in there, had to lance that area, ligate the vessels, because she was just continuing to lose volume into her tissue. So we always want to assess the perineal area of our clients, especially clients that have had significant lacerations. We talked about that with the well postpartum period. So 3rd and 4th degree lacerations. I want to see what this area looks like. Severe lacerations can lead to a hematoma. I want to see where I'm starting from, because as the bleeding continues, the hematoma is just going to get darker and fuller. I want to see what it looked like at the beginning. I want to get a baseline. Okay, so Sarah's gone, you return back to Lauren. Lauren continues to receive blood, her vital signs are normal. You look through her chart and you see that during labor she had a fever of 101.2. Is an elevated temp in labor normal? Elevated. Elevated can be normal. We already said this, if it's higher than what? 100.4, we have to investigate. Was Lauren's temp normal? At 101.2. No. What are some signs of potential complications we need to watch for now that she has delivered? So she had an elevated temp during labor. She's delivered now. Can we just say, okay, that's over. Now we're good. Okay, continued infection. What is infection? So when you have a pregnant client, still pregnant, running a high fever, what is that called? Anybody know? Anyone here take care of a client in labor with a high fever? Oh, you guys got some great clients. Oh. So it's called chorioamnionitis. Does that term sound familiar? Yes. It's an infection of the amniotic membrane or the amniotic fluid. Chorioamnionitis. Now the amniotic fluid and the chorionic and amniotic membrane are gone. So maybe the infection is gone. Possibly. Is it guaranteed? No. The chorionic and amniotic membrane are adhered to what? The inside of the uterus? The endometrial lining of the uterus? So if the chorionic and amniotic membrane are infected, could the endometrial lining of the uterus become infected if they're right next to each other? What is that called? Endometritis. Not every client that develops chorio will go on to develop endometritis, but it's definitely a risk. Once the membrane is gone, that's fine, that's good, but we still have to keep watching. Things that we're watching for: uterine tenderness. If her uterus becomes infected, it will be tender. Much more tender than just a regular person who's had a vaginal delivery or even a C-section delivery.
Would it just be for like a patient who has a C-section, they just have a more severe tender uterus?
Yes, and a high fever.
Yeah, I just like to determine the type of tenderness of the uterus.
Yes, significantly more than you would expect. Increased bleeding. Why increased bleeding? Okay, so if we have endometritis, if the lining of the uterus or the uterus is infected, do infected organs work as well as non-infected organs? What is the role of the uterus after delivery? To contract. If I have an infected uterus, it might not do its job as well as one that's not infected. How about foul-smelling lochia? What does that mean? I've had students say, well, lochia, no lochia smells good. How will I know if it's foul-smelling? What is foul-smelling lochia? Yeah, it smells like rot. BB smells like fish. A little bit different. It's definitely more pungent. Lokia kind of normally has a little bit of a musty odor, but it's definitely more than musty. It's usually hard to miss. And the potential surgical site infection, why is that? Yeah, because if the endometrial lining of my uterus is infected, the bacteria can just crawl right into that uterine incision, right? And now I have an infected surgical site. What are some signs we should be watching for to know that Lauren may be developing a surgical site infection? I'll give you guys a minute to think about it and then we'll get back together. I'm gonna go over here. What do you guys think? Redness? What else? Redness, swelling, warm, purulent drainage, increased pain. Wound edges might start to pucker or pop open. We're gonna have a fever. So this is actually a pretty tame picture of a surgical site infection. You can see the kind of purulent, oh, I forgot my phone doesn't work. The kind of exudate white discharge there at the top right-hand side of the area that's popped open. We have redness, it's definitely come apart. So clients that have choreo can go on to develop endometritis. Clients that have endometritis can go on to develop a surgical site infection. So these are all risk factors for one another. What are some other complications related to C-sections, aside from surgical site infections? What do you guys think over here? What are some other complications of C-sections? Okay, potentially increased bleeding. How about over here? Okay, infection. So we have infection. We have bleeding. Anything else? Okay. That would be like, yeah, that would be excessive. A uterine rupture. Anything a little bit more like common? Okay, constipation can count. Anything else? Immobility leading to? Huh? Blood clots. Okay, so some complications, constipation, you guys said that, and deep vein thrombosis. Both of these are exacerbated by immobility. For those of you that have taken care of a C-section patient, do they normally just hop out of bed once they roll out of the OR? Like vaginal deliveries do? So usually once a client has a vaginal delivery, as soon as the epidural wears off, they're up and moving and grooving, right? C-section patients are not like that. They're immobile for usually several hours. So let's talk a little bit more about DVT. We have one client that we haven't seen yet. So, women who have C-sections are at increased risk for DVT. Once again, this is a review from our well postpartum. What are some signs and symptoms of DVT? Okay, unilateral edema, unilateral pain, unequal pedal pulses, unilateral change in temperature, unilateral change in color. Very good. The top picture is 2 normal legs. The bottom picture is a client that has a DVT. Can you guys see the difference? How can we prevent this? Or what are some ways we can try to prevent it? Okay, SCDs, well, we would like them to ambulate as soon as possible. That's the best way. The absolute best way to prevent DVT is early and frequent ambulation. No matter what patient you're taking care of, any post-op patient, I guarantee the nurse is going to want to get them up and ambulate as soon as they are able. Lauren's not able to ambulate yet, so now we have to, fall back on some other things. Not the best, but better than nothing. And this is where the SCDs fall in, right? SCDs, range of motion exercises in bed, TED hose, all of these things are for clients that cannot ambulate. Clients that can ambulate, we need to get them to ambulate. Okay. Now, care of a DVT looks a little bit different than preventing a DVT. So we're going to move on to Anna. So Anna's a 37-year-old G4P3. She delivered by C-section 4 days ago. She admits to smoking a half pack of cigarettes a day. She was diagnosed with DVT after complaining of pain in her right leg 24 hours after her C-section. What risk factors do you see in Anna's history for DVT? Smoking, what else? Her age, what else? C-section, multiparity, smoking, C-section, over 35. Just like Lauren was a setup for hemorrhage, Anna's a setup for a DVT. What are some other risk factors that we would be looking for that we know would put our client at risk for a DVT? Obesity or overweight, operative vaginal delivery, immobility, or simply a history of blood clots. So Anna's receiving heparin therapy and has been on bed rest for the last 3 days. She's concerned that she's not been able to take care of her baby. She feels she's putting too much strain on her partner. Why is it important that Anna stay on bed rest? Okay, so doesn't this dislodge and turn into an embolus? It could dislodge and travel to her heart, to her lungs, anywhere in her body. Yes. So a birthing client that's paralyzed, how do we prevent DVTs, SCDs? Range of motion exercises. Not everyone can walk. There's been a couple of times in my career that I've helped take care of a paraplegic who was having a baby. And this is what we do. They're at increased risk for developing a clot for the first several days after delivery, but once those pregnancy hormones kind of dissipate from their system, then their risk of clot is still greater than anybody else. Pregnant and early postpartum are at greater risk for clot because of the pregnancy hormones causes them to clot faster. So some interventions, we would want to elevate the leg. Do not massage, even though it's going to ache. They're going to be tempted to rub their calf or rub their leg wherever it's hurting. Don't do that. We give them analgesics for pain. Do we want this client to be up moving around? No. And because she's on heparin, we're going to watch for signs of bleeding. She still has a placental site, yes. She still has a surgical site, yes. So she can still bleed from both of those sites. And now we're giving her medication that's going to prevent her from clotting or reduce the likelihood that she can clot. So we also want to watch for bleeding. So we said that a client that has a DVT, it can dislodge and become a pulmonary embolism. How would we know? What would be some signs? I'll give you guys a minute to think about it and then we'll get back together. I need signs of pulmonary embolism and some nursing interventions.
Signs. Short of breath, pain. Possibly self-report, but not usually. So it's going to be short of breath. Decreased SAT.
And what did you say?
Decreased oxygenation. Decreased SAT.
Symptoms of pulmonary embolism. Cough, dyspnea, chest pain, tachypnea, tachycardia, lower oxygen saturation, cough, chest pain, tachycardia, tachypnea, dyspnea, low oxygen saturation. What are some nursing interventions? What should we do? Provide oxygen. Alert the provider. Elevate the head of the bed. Raise the head of the bed, provide oxygen. Notify the doctor. And they're probably going to order something to break up the clot. Yes?
We had a question about medication. So, like, this patient is already receiving heparin, or most pregnant postpartum would have like PRN, thrombolytic medication already.
So the question is, do most postpartum clients have a thrombolytic medication ordered to be administered as needed? And the answer is no. No, this is something that we would call a stat OB code. They would run to the room and we would administer something like then and there. What we can do until everyone gets to the room is elevate the head of the bed, provide oxygen, keep the patient calm, and hopefully they'll be there within minutes. Okay, so Anna's doing fine. She doesn't develop a PE. She does have a DVT, but she's stable. She's receiving her heparin. Aside from being bummed because she has to stay in bed, she's all right. Okay, so after talking to Anna, you move back to Lauren. She's been withdrawn and quiet since she arrived to your unit after delivery. You ask her if there's anything you can do to help. And she says that she really wanted to do skin to skin and breastfeed, but because of the stat C-section, she wasn't able to. She knows about the importance of skin to skin and how it helps with bonding and breastfeeding, and she worries that she's missed her chance. What can you tell her? Yes.
So, my son was in the NICU, and one of the things they said is they brought his clothing or like what he was wearing. So when I was talking
Okay. So they can bring something from the baby to you and from you to the baby to help with that connection. Is bonding an all or nothing thing?
But, I mean, one thing that you can tell her too, if she wanted to breastfeed, so like that, her milk isn't committed, so. It's not like she won't have the ability to start.
Yeah, and any client, like you were saying, your son was in the NICU, what did they provide you with? A breast pump, right? So bonding isn't an all or nothing situation. You can offer to take her to the NICU to see her baby once she is stable. Or back in the day, we had a Polaroid camera on the labor and delivery unit. We would run up there, snap some pictures of the baby and let the family have the Polaroids. I hear Polaroids are coming back. They're making a comeback. Wow, that's old. I can't believe. I don't know, that's funny to me. Because everyone now has smartphones, right? So you send the family or the partner or the husband or the mother or someone upstairs to snap some pictures on their smartphone. This was back before people had smartphones. All we had was a Polaroid camera. But something so she can see the baby. If she can't get up and go to the baby. So Lauren's complications at delivery is a risk factor for postpartum depression. We know that. What are some other risk factors for postpartum depression that we should be on the lookout for? Because we know that the more risk factors a client has for a particular problem, the more likely that problem is to manifest, right? So does she just have one risk factor for postpartum depression, or does she have others? What are they? Or emergency C-section, it's definitely. Any other risk factors for postpartum depression? History of postpartum depression? Very good. Lack of support? Have I said anything about any sort of support? Partner, friend, mother, sister, boyfriend, husband? Have I mentioned anybody? Nope, I have not. Do we get clients like this sometimes? That they're just there by their little lonesome? Sometimes we do. Lack of support, history of postpartum depression or major depression. Body image issues, eating disorders, stressful life events. They actually did a research study, and they determined the length, like the time that someone was going through a stressful experience was more predictive of their likelihood of developing depression than when it actually took place. They were looking at clients that were homeless. The more years someone spent on the street, so they might spend 5 years on the street 3 years ago. That was more of a risk factor for postpartum depression than actual homelessness during the pregnancy. Because it's all about how long this stressful event took place, how significant it was. So if she's had a really hard life, even if things are somewhat stable now, she's more at risk for developing postpartum depression, like I said, even if everything is sunny now. What is our main concern in a client with postpartum depression? Okay, potentially abusive behavior towards baby. That's actually not our biggest concern. Huh? Self-harm. The only difference in the DSM-5 between postpartum depression and major depression is the time it occurs. Everything else is exactly the same. A depressed person is much more likely to hurt themselves than they are to hurt someone else. If the infant is harmed, it's usually out of neglect, not out and out abuse. So harming herself is what we worry about. What are some symptoms that differentiate postpartum depression from postpartum psychosis? I'll give you guys a minute to think about it, and then we'll get back together.
I would think we would hear like voices.
What symptom differentiates? Yeah, right.
That is one thing
Mental.
I wanted to say. I've never known anybody to have depression. Yes. So.
Yeah.
I'm gonna go over here in the corner. What do you guys think? What are some differences between postpartum depression and postpartum psychosis? Okay, the onset, potentially. Okay, the main thing is the symptoms. Delusions, hallucination, confusion is never normal. It's never normal, okay? And it's not a sign of depression. Hallucinations and delusions are not a sign of major depression. Disorientation and confusion is not a sign of major depression. Your client should always know who they are, where they are, what is going on, whether they're depressed or not. What are some risk factors for postpartum psychosis? What you guys say here? Okay. Not as significant. A history of postpartum psychosis, definitely. History of mental illness, specifically what? Bipolar, schizophrenia.
I need it now.
Very good. What is our biggest concern when it comes to these patients? Self-harm and
Baby. Harm to the baby.
harming the baby.
I feel like we've done this already.
Who knows who Andrea Yates is?
Uh-oh. La Llorona.
For those of you that think you know who Andrea Yates is, raise your hand. Who knows who Andrea Yates is? Oh, okay. Who's Andrea Yates? Okay, fine. She is a mother who had a history of schizophrenia and postpartum psychosis, and who drowned all 5 of her children in a bathtub. This made national news. It happened right here in the great state of Texas. I was in North Carolina. I'm like, what the what? This made national news. So she's from Houston, Texas. She confessed to drowning all 5 of her children in their bathtub June 20th of 2001. She had a history of severe postpartum depression, also postpartum psychosis, and a history of schizophrenia. She was actually told after the delivery of her 5th child, or her 4th child, that she should not get pregnant again. She absolutely should not get pregnant again. And so what did she immediately do?
Get pregnant.
Get pregnant again. And then her husband was told, you absolutely cannot leave her alone with the children. Under no circumstances is she to be left alone with the children. So
What did he do?
he stayed home for a while, but there was one day where he had to go into work, and her mother was coming, and there was just going to be about a 30-minute window between the time that he left and her mother got there. And that's the point in time where she took all 5 of her children one by one into the bathroom and held them under the water in the bathtub until they all died. She's a very, very sick lady. If you don't know the story of Andrea Yates, she is a textbook example of postpartum psychosis. If you want to understand postpartum psychosis, you should read her story. Andrea Yates. She's actually still alive, living in Houston still, I believe. I think she's still an inpatient at the mental hospital there. Her husband, Rusty, divorced her very soon after this happened. Can he be charged with anything? I don't know if they tried. I know he was never charged with anything. She was actually charged with first-degree murder, and then they rolled it back, and they determined that that she was not guilty by reason of mental defect or something like that. Okay. So Lauren, she did end up being diagnosed with endometritis, and so therefore she has to stay in the hospital for a few more days to get IV antibiotics. Her baby was released from the NICU on day 2. On day 4, she's complaining about her breasts being sore and firm. She states that her sister developed mastitis, and she wonders if she has the same thing. What are some signs of mastitis? Okay, fever, redness. Redness where? On both breasts?
No.
So unilateral redness. Okay. Unilateral edema, right? Swelling. redness, pain, fever, chills, flu-like symptoms. Usually occurs between 2 and 8 weeks postpartum. Redness, warmth, and swelling of one breast. Unless she develops mastitis simultaneously on both sides, most women, it's kind of like DVT, it's going to be unilateral. Here's a picture of what you might see. You guys see that red swollen area? Very painful. Oops. Y'all didn't see that. So Lauren doesn't have a fever. Well, she has a low-grade fever, but she doesn't have unilateral redness, swelling, pain, heat. Why are her breasts sore and firm? Engorgement. Her milk has come in. We don't normally see this in the inpatient setting because breast milk comes in when? Day 3 to 5. They're usually gone by day 2. But sometimes, for whatever reason, they do have to end up staying with us in the hospital. So we have to be, not just, educate on signs of engorgement, but we also have to be on the lookout for it ourselves. So her plan was to breastfeed before her baby went to the NICU. So what should she have had right after delivery? We should have made sure that she had what within the first few hours after birth, if it was her plan to breastfeed and her baby went to the NICU? A breast pump. Very good. So on day 5, it's finally determined that Lauren's stable enough to be discharged. You're performing discharge teaching, and even though Lauren has other children, you want to ensure that she understands how to take care of this one. You never want to assume that someone, just because they've given birth before, that they automatically know exactly what to do. I think I told you guys my story about my 2 children and putting them to sleep on their back versus not. I also got the pleasure of taking care of a young client who this was like her 3rd kid, and I naturally assumed that she would have some basic information, but I learned later that her first 2 were taken from her very soon after delivery and put in the foster care system. So this was the first one she was going to be able to keep. Do I need to make sure she knows how to take care of this baby? Yeah, we don't want to assume just because someone has given birth, just because they have pregnancy and birth in their history, that they know everything. What are some ways that we can make sure Lauren understands how to safely care for her baby? Okay, teach back. Teach back is a good way. What else? Either have her summarize in her own words or watch her. So I said, what is the best way? The best way to determine whether or not your client understands something is have them explain it to you. Kind of like I do with y'all, right? The best way to ensure that your client knows how to do something is to watch them do it. Is this the most time-efficient way? No. This is very long. It's much faster to rattle off a lot of information and then say, you have any questions? That's much faster, much easier. But have you guys ever been so lost that you couldn't even form a question? Mm-hmm. Like you didn't even have the ability to put together a question. So just because someone doesn't have any questions doesn't mean that they know everything. I don't know if I'm going to be able to show this. I'm not sure if this room has speakers, but we will try.
after dozens of phone calls to psychologists to see if I can get an appointment, which would take weeks, you know, I don't know if I would have survived, honestly, waiting 6 weeks. I needed something right then and there, and I couldn't find it. The help wasn't there.
I would have wanted to be screened. I would have absolutely wanted to be screened. Right away, I knew something is not right.
Hemorrhage is a common postpartum complication. Actually, so is suicide.
45-year-old mother holding her son plunged 8 stories out of an apartment window to her death in an apparent suicide.
She had already driven in off this boat ramp here right into the Hudson River.
These are very real illnesses, and they need to be taken seriously.
This is the gap that we find mothers in all the time. They go to the OB says, oh, you're having a mental health complication, go to the psychiatrist. They go to the psychiatrist, they say, you're pregnant, you've got to go back to the OB. And they're left in this place where they fall through huge cracks.
High blood pressure gets treated, diabetes gets treated. Treating mental health is optional.
I really didn't receive the help I needed, and anything I kind of found on my own was just on the internet.
This is a public health issue. This is not a woman's issue. This affects everybody. It certainly affects her children.
Anyone would have asked me. I said, yes, I need help.
Are you guys surprised that postpartum depression is more common than hemorrhage? No. Significantly more common? That doesn't surprise anybody? I don't know if it's globally. It's definitely the case here in this country. 1 in 7 women. What did the First Lady say? If anyone would have asked me, I would have immediately said, I need help. Whose job is it to ask? All of us. All of us, right? So we just want to keep that in mind. We need to be screening our clients. We need to be asking them questions. We don't just want to assume that everyone who has a healthy, happy, cherub little baby is okay emotionally themselves. Okay, you guys ready for our critical thinking question? So the nurse is caring for a client 2 hours after a spontaneous vaginal delivery. The client has saturated 2 peri pads in the last 30 minutes. Which of the following is a priority nursing intervention at this time? Is it A, B, C, or D? You guys can deliberate with your table, and then when you think you have an answer, write it on your paddle.
Okay. What do you go with?
What do you guys think over here? Okay, I see lots of A's. Very good, you guys are correct. The first thing we want to do is determine what the fundus is firm, because that will allow us to pick the next best intervention. If her fundus is firm, some of the things we probably would have wanted to try, like massage and stuff, is that going to work? No. Okay, the nurse in a clinic is caring for a client who's 3 weeks postpartum following the birth of a healthy baby. The client reports feeling down and sad, having no energy, and wanting to cry. Which of the following is a priority action by the nurse? Is it A, B, C, or D?
B.
Okay, I see lots of D's, and you guys are correct. Very good. The nurse is caring for a client who's 12 hours postpartum. Which of the following findings would alert the nurse of a possible postpartum complication? Is it A, B, C, or D?
It is elevated. The urine output is 30 minutes an hour. 30 an hour, right?
Yeah, and that's gonna be 100 or 100 an hour.
What do you guys think over here?
That's the only one
I see lots of D's, and you guys are correct. Is orthostatic hypotension an abnormal finding in the postpartum period? No. Is a fundus palpable like the umbilicus normal at 12 hours? Yes. Is urine output of 1,500 mLs in the last 12 hours, is that outside of reason? No, because they diurese, right? They diurese at this point in time, and they just start peeing like a Russian racehorse. Now, is tachycardia normal? No, it could mean hypovolemia, it could mean pain, it could mean a lot of things that we would want to address. Last one. So your patient's recovering following a C-section due to labor dystocia from a macrosomic baby. Your patient is 40 years old and moderately obese. She suddenly complains of difficulty breathing and chest pain. Which of the following is the priority nursing action? Is it A, B, C, or D?
Start with that. Start with A.
We would want to sit them up, but we don't need to administer Zantac, right? These aren't signs of indigestion, these are signs of pulmonary embolism. In order for the option to be correct, everything in the option needs to be correct. Any questions? Anyone have any questions about any OB questions from the quiz today? Well, come and talk to me.
Oh, I got it.
Yes, I'm sorry. Go ahead and bring your paddles and markers up here. Sorry.
Bye.